Welcome to the SIBO Doctor podcast with Dr. Narala Jacoby. If you're a practitioner and want to learn the basics of SIBO, head over to sibotest.com and sign up as a practitioner. This will give you access to a free 90-minute webinar on the fundamentals of SIBO treatment. If you're a patient, please know this information is not intended to diagnose or treat a medical condition. Please ask your doctor before initiating any new treatments. And now, over to Dr. Jacoby and the SIBO Doctor podcast.
If you're like me, you're finding that treating small intestinal bacterial overgrowth can be complicated. Patients often present with a myriad of symptoms and associated conditions which require holistic thinking and a methodical approach to treatment. This podcast was born out of a desire to start a conversation with other practitioners, educators, experts, and researchers, and see if their insights can give us new treatment considerations, especially for our difficult cases. In this podcast series, our guests talk about functional gut disorders, hormonal issues, the enteric nervous system, food intolerances, the immune system, the microbiome, methylation and genomic issues, and everything else that can make a SIBO case very confusing. I believe that by understanding the often complex interconnection of SIBO with other disease manifestations, we can be more effective in our treatment approaches. I hope you find this podcast useful in your practice, and thank you for listening.
Build your clinical confidence as a SIBO treating practitioner. The SIBO Masterclass is now available at sibotest.com. Presented by Dr. Narala Jacoby, this masterclass covers a wide array of topics in advanced SIBO case management. Learn about implementing Dr. Jacoby's biphasic treatment approach, in-depth herbal protocols, how to manage food intolerances such as salicylates and histamines, methylation and nutrigenomics in chronic gut cases, and much, much more. This course is presented over 4 modules and is available for immediate download. Enroll today and download this incredible tool so you can help even your toughest SIBO cases today.
Well, welcome SIBO practitioners. Today I'm speaking with Dr. Michael Ruscio. Dr. Michael Ruscio is a functional medical practitioner, chiropractor, also very much interested in clinical research. He is the host of the Dr. Ruscio radio podcast that many of you may know. And we recently presented at the Integrative SIBO conference in Chicago and just caught up with him, and I thought it would be great to have him on the show because one of his specialties is looking at the gut-thyroid connection and specifically how it relates to SIBO. So welcome, Dr. Ruscio.
Hi, thanks for having me.
Great. So let's dive right in. Well, before we dive right in, I wanted just to know, how did you actually get interested in SIBO?
Right. Well, it's a great question, and I think the answer is probably not too dissimilar to many other healthcare practitioners where I had my own health experience with this. I was in my early 20s. I think I was 23, and I was attending university on par to go into conventional medicine. That's what I wanted to do, was conventional medicine. But I ended up having, I didn't know it at the time, but I actually had an intestinal amoeba infection that wasn't really manifesting as any digestive symptoms as amoebiasis typically would, like diarrhea or what have you, but rather manifested as pretty debilitating insomnia, fatigue, and quite a bit of brain fog and depressions of mood. Also was losing a little bit of muscle mass, feeling kind of cold, and also had some thinning hair. So I actually thought I had hypothyroidism at the time based upon the symptoms, and went and saw a few conventional doctors locally, figured, okay, I used to feel great, now I feel not great. This is what doctors are for. I'll go see a doctor, they'll figure it out, and everything will be fine. And of course, I had a bunch of tests done conventionally, and nothing was found, and everyone told me how healthy I was when, sure, in front of someone as a college athlete, I'm sure I looked healthy on the surface, but underneath that, I was not doing well at all. Especially the insomnia was just terrible. So I ended up finding a functional medicine practitioner, and they found that I had an intestinal parasite. And at first I thought the provider was crazy because I hadn't had any of the keynote presentation that accompanies a parasite. I didn't travel and have food poisoning or acute gastroenteritis that predated all this, and I had virtually no digestive symptoms, but it ended up being true, and that was the only treatment that really helped me feel better. I had been doing a lot of kind of do-it-yourself herbal protocols for low thyroid and low testosterone and everything else, and just kind of spun my wheels and wasted a bunch of money, only to figure out that the ultimate cause of my symptoms was really this problem in the gut. And so I changed the course of my future there. I decided to go into alternative medicine and kind of pursue this gut-focused alternative medicine practice model, which is what I do now, and it was great. I mean, it sucked at the time, but I'm so happy that it happened because I'm really passionate about what I do.
Yeah, I do think that that's what brings many of us into that field, or at least this area of specialty. And you also have a book coming out very soon that you've been writing for some time about microbiota and health in general. So we're really looking forward to that. I know that the title is pending, so I can't make any announcements, but we will be looking forward to that. And also, I forgot to mention that you'll be at the Metagenics conference in June in the beautiful Hunter Valley down here in Australia, New South Wales. So really looking forward to seeing you there. All right, great. So let's get right into the nitty-gritties of gut-thyroid connection. And you frequently talk about that on your podcast and also in your blogs and so forth. So can you just expand on what you think the gut-thyroid connection is?
Yes, and gosh, that's such a loaded question, and there's so much to say there. I was thinking about that before we got on the call, and maybe I can codify that down or organize that down into four areas. The way that the gut affects thyroid autoimmunity, the way that the gut affects thyroid hormone absorption, like a medication or medication like levothyroxine or what have you, and the way the gut can cause hypothyroid-like symptoms even when thyroid hormone levels are normal, and also the fact that those who are on thyroid medication and or who are hypothyroid have an increased risk of SIBO. So there's definitely a few components to that, and I guess I can just kind of launch in with a few examples that illustrate each one of those components, and we can kind of hash it out from there.
Great.
The first one, and I know you wanted to kind of get into some of the more details on this, and this is actually admittedly a very interesting study. The title of the study was Levothyroxine Therapy and Impaired Clearance are the strongest contributors to small intestinal bacterial overgrowth, results of a retrospective cohort study. And essentially what this study did was it pervaded about 1,800 patients, and it was trying to answer the question, what are some of the risk factors for development of SIBO, and just looking at all their patients and trying to see, well, if you had intestinal surgery, would that be a significant risk factor for SIBO? If you were on immunosuppressive drugs, would that be a risk factor for development of SIBO? If you were on prolonged acid suppressing medication like a PPI, would that increase the incidence of SIBO? And what they found was actually pretty shocking, and I wasn't expecting them to find this, but they found that yes, immunosuppressive drug use was a risk factor. Even more so than that was, but even more so than the use of immunosuppressive drugs or having previous intestinal surgery, you were even at more risk if you were either hypothyroid or even more so if you were on thyroid hormone medication, namely levothyroxine. And so what this shows us is that there's something, and I don't think we fully understand exactly what, but there's something about being either hypothyroid or being on thyroid medication that increases risk of SIBO. And that was a pretty keynote study. I guess I'll pause there for a second in case you want to get into any of the details on that one.
Yeah, so I was like, that whole study was pretty interesting, as you said, because there were so many different parameters that they looked at. And I had sort of some questions as to where these people that were on levothyroxine actually, where their diagnosis hypothyroidism, where the hypothyroid patients classified as just hypothyroid, some of which received levothyroxine and some of which didn't, so that was slightly confusing for me. And there were some interesting conclusions at the end of the study, but I'll let you go on about that. But that was like, why did they differentiate it like that? That was one of my questions, and I looked through all of that, I couldn't find it. So do you have any idea about why they did it like that?
You mean the delineation between hypothyroid and those who were on levothyroxine?
Yeah, because they had categories of hypothyroidism, and then one of them was just hypothyroid, and the other one was levothyroxine users. Weren't these guys also, hypothyroid? So that was just one thing.
Sure. I believe that the hypothyroid group, they were treatment naive, meaning they hadn't yet been put on thyroid medication. And then, of course, the people on levothyroxine had previously had their hypothyroidism identified, and they had been on medication. And there's actually something really interesting, I think, in that finding, because it would be easy to assume, okay, you're hypothyroid, and that's why you have SIBO. But the people who are on thyroid medication actually had a slightly higher risk of SIBO compared to those who were hypothyroid, meaning they were untreated. And so maybe to clarify, people who are on levothyroxine, they're not truly hypothyroid anymore, right? They're taking the hormone exogenously, and now their hormone levels are actually in the euthyroid levels.
Okay, but both categories theoretically are hypothyroid, right? Doesn't matter. It's just a small thing.
They both have the same underlying. Yeah, they both have the same kind of underlying, issue, right? It's like you have someone who is a diabetic and someone who was a diabetic, but now they're on a medication, and so their blood sugar is normal.
Okay, so that's how they delineated that. Because if somebody is on levothyroxine, they would still carry the diagnosis of hypothyroidism. I think we're just splitting hairs, but for me it was like, okay, why did they do it like that? Because to draw a conclusion like that from a big study like that, where PPI therapy use was also very high, as you know, in that study, and they just sort of like blanket stated that levothyroxine may cause SIBO. So I thought that was maybe a slight reach. So I'm really curious what your thoughts are on that and why it would cause it.
Well, coming back to your earlier point, which is totally correct, which is if someone's on medication, they still carry the diagnosis of hypothyroid, but now if we look at their blood levels, their levels of hormones are normal, right? So a treated hypothyroid person will have normal thyroid hormone levels, and an untreated person will have hypothyroid levels on their lab test. So that was like the main delineation. And what was interesting is that the people who were untreated actually had slightly less risk than the people who were treated, which may mean that it's not dependent, the risk of SIBO that is not dependent upon your thyroid hormone levels being hypothyroid or now being in the normal range. It may have to do with just the underlying thyroid disease process. Those who had more severe thyroid disease are more prone to have hypothyroidism diagnosed and treated. And it seems even after treatment with hormones, they still had a higher risk of SIBO. This suggests, we really don't know this, but I'm just speculating, but it suggests that it's not so much the thyroid hormone levels, but the underlying thyroid disease, maybe something that has to do with the inflammation of the disease and how that affects gut motility, perhaps. That is the biggest risk factor.
Because one of their last conclusions about that their study was that it probably wasn't related to motility because levothyroxine would increase motility. So the connection was like, well, what is it that's then causing an increased incidence of SIBO in those that receive that medication? So very, very interesting. I don't want to dwell too much on this study, but the only other kind of tiny bit of a red flag for me in that study was that they used 25 grams of lactulose, which is about 2.5 times the normal amount that we use in a lactulose breath test. So I wonder if that had, I don't know. I'm just wondering if that had any impact on the outcome, but that we would have seen that across the board, But it will definitely increase motility if you give somebody a lot more lactulose than 10 grams.
Right. And what's also interesting is that even hyperthyroid patients also showed this increased risk. Not quite as much, but hyperthyroid patients. So, and I was using the term motility loosely before, and I'm glad you corrected me on that. Maybe to say it more accurately, maybe it's something that has to do with how the inflammation associated with thyroid autoimmunity affects other apparati in the gut. Maybe the gut immune system, it has a hard time monitoring commensals or what have you. But it might be, and I'm just speculating, but it might be something that has to do with the foundational kind of pathophysiology of thyroid disease, potentially inflammation, and how that affects these things broadly. And I should maybe also mention, if people want to get a detailed write-up of this, we will have this. We have a practitioner-only newsletter where we review studies like this, and I kind of break out all the bullet points. So it's because sometimes it's hard to find the time to read a complete study. So what I do is I'll read the study, and then I'll just kind of give you a bullet point summary of the study. That makes it a lot easier to, with the interpretation provided. So it makes it easier to kind of, take a study that may take you an hour to fully read and interpret, and then you have all the bullet points listed there for you, and maybe in 10 minutes you can take away the same that might take an hour to an hour and a half. So that'll be going out at some point in the next couple months.
That's great. Yeah, I think we'll talk a bit more about that at the end. I think you have some other offerings for practitioners, I think, that you had in the makings. So, but let's get back to the 4 points that you mentioned, that you sort of how you categorize the gut-thyroid connection. And just to clarify for myself, so when you say hypothyroidism, do you always mean Hashimoto's, or do you mean generally even those that do not have an underlying autoimmune condition?
It's a great question. I think it's important that we're careful in our wording, especially for practitioner conversations. It's easy when you're trying to communicate with the public just to kind of use a catch-all term like hypothyroid. But specifically, what do you when you say hypothyroid, what do you mean? Is that person hypothyroid treatment naive? Are they hypothyroid and they're managed? Is it Hashimoto's hypothyroid? Is it subclinical hypothyroid? So it is important to be clear on the wording. And I'd maybe like to come back to that in 1 second. Because there's a couple other things that I wanted just to establish from the gut perspective. And then I have a few pieces in terms of how we define hypothyroid that I think will flow a little bit better once we establish that premise. So do you mind if I give a couple other of these pieces? Okay. So there's another study here that ties in with kind of this gut-thyroid connection, which is that SIBO has been found to be more common, according to a couple studies. SIBO has been found to be more common in those with H. pylori. And so SIBO and H. pylori tend to go together. And even more so, what's been found is risk of SIBO increases even more after conventional treatment of the H. pylori, potentially because of the antibiotics that are used, potentially because of the acid-suppressing medications that are used. But for whatever the reason, we see a SIBO-H. pylori connection. We see the risk of SIBO increase after eradication of H. pylori. And then this ties back into autoimmunity because we do have pretty high-level scientific data, most namely a meta-analysis, which is probably the highest level of scientific data one could have, showing an association between H. pylori and thyroid autoimmunity. And even more important than that, there's been one keynote study that displayed in those with Hashimoto's treatment and H. pylori, treatment of the H. pylori actually was able to decrease thyroid autoimmunity. So there's kind of a string there of different facts that all kind of tie together. But we talk a lot about SIBO. SIBO has been shown to be associated with H. pylori. Treatment of the H. pylori increases risk of SIBO. H. pylori has been associated with thyroid autoimmunity, and treatment of H. pylori has been shown to help improve thyroid autoimmunity. So there's definitely a lot going on between the gut, SIBO, H. pylori, and thyroid autoimmunity. So I just wanted to kind of throw that out there because I think H. pylori is important to keep in mind, especially if you're talking to a SIBO patient and they're worried about their thyroid. H. pylori would potentially be important to also factor into your clinical process.
So fascinating. One of I'm sure undoubtedly you know about Martin Blaser in his book Missing Microbes, where he talks about H. pylori in his studying that organism. I'm always so fascinated when we're seeing this these ancient organisms that we co-evolved with be implicated in some massive way that is just beginning to be elucidated. And it begs the question, are there others? We're starting to see a little bit more with Klebsiella and ankylosing spondylitis, for example. That was been around for a little while, but to actually have an underlying driver of an autoimmune condition that's infectious is not new in terms of concept, but to actually start to connect the dots is really exciting. So are you always treating H. pylori when you find it, even if people are asymptomatic?
And that's another great question because, as you're alluding to, not all of these organisms are necessarily problematic, right? There's some other evidence that shows H. pylori is even protective against autoimmunity. And to, step into a quick tangent, in my mind, part of it may have to do with the H. pylori and the immunocompatibility of the strain of H. pylori and the host. Mm-hmm. So some of that has been shown that certain virulence factors may predict pathogenesis or commensalism. But also, I think the timing of inoculation with the H. pylori is also very important. And this may be why we see H. pylori shown to be protective against some forms of autoimmunity, because it may be that the H. pylori is actually a proxy for a dirtier environment. And when I say dirty, I just mean more germ-rich, more hunter-gatherer-like, meaning people don't have quite the same high level of sanitation. They have more exposure to environmental dirt, bacteria, animals, what have you. And those people become inoculated with H. pylori earlier. And so part of the reason why we may see some evidence showing that H. pylori actually protects against autoimmunity may be because we're looking at these populations that have a higher colonization density with H. pylori, most of that occurring early in life when these inoculations tend to be protective. But if these inoculations happen after the microbiota immune window has kind of closed after maybe 3 to 4 years of age, and someone first is inoculated with H. pylori, let's say at 18, 25, 38, what have you, then that person's immune system may no longer be receptive to it, and it may be perceived more as a pathogen and kind of stimulate this infection-mediated initiation of autoimmunity. So the timing of the H. pylori inoculation, I think, is important. But clinically, we don't really have a way to really parse that out. It can be very difficult if someone comes in and they're 42 and they're complaining of symptoms, and you find H. pylori, and to your question, is this H. pylori functioning in a protective way or in a pathogenic way? It's hard to know, but what I like to do, and the way I like to look at this, is not as strictly eradicating H. pylori, because there's, I think, more evidence surfacing lately that's showing that we don't ever truly fully eradicate H. pylori, but we rather kind of get it back into balance with the other members of the microbiota.
I like that.
And so if you look at it through more...
That's what I do. Yeah, that's my sort of thing. If the 50% of the world is positive for an organism, then it's kind of maybe just like, as you elegantly put it just now, sort of like almost like a canary in the coal mine. It depends on the other factors of what's happening in the gut that maybe even also determine its virulence. So,
Exactly. And if we use natural treatments, I think we really mitigate potential risk. And so even if someone doesn't truly need to have their H. pylori colonization level recalibrated, if you will, it's difficult to say you're going to do a lot of harm if you use something like a probiotic, an herbal antimicrobial, and N-acetylcysteine, 3 things that can be very helpful for helping to recalibrate the equilibrium of H. pylori with the microbiota. So I think you really have a minimal risk for any overt damage by using some of these natural agents because they're a little bit more mild. And it is interesting to see that things like probiotics are shown to be pretty helpful with H. pylori, even when they're used synergistically with antibiotics. And maybe this is because the probiotics have all these other positive benefits that help kind of balance out the gut and help heal the gut. And so again, maybe it's more so an issue not of just strict eradication, like kill, but more so just trying to recalibrate that ecosystem and let H. pylori then be policed by the other guys in the gut.
It's sometimes, and you and I have sort of commiserated. I think you and I have commiserated about the intense, like the patients that are coming to see us with gut issues. In my 20 years of doing this, when I first started out, I think people are getting sicker in terms of their gut. And sometimes it's really difficult to do what you just said in terms of recalibration. But that's why we're talking, so it's good. So moving back to the thyroid, do you focus mainly on Hashimoto's, or can we just sort of if we just start talking about Hashimoto's, we'll talk about leaky gut and autoimmunity and things like that, but I'd also want to keep in mind to address other levels of hypothyroidism in terms of,
Sure.
you're coming to Australia, so it's very, very iodine depleted here. And there are just also nutritional factors, which I wondered if, obviously with SIBO, you have malabsorption very often of nutrients, which can also obviously set someone down the path of hypothyroidism if they're very deficient of tyrosine or iodine or a number of other things. So, but would you prefer just to kind of go into more of a Hashimoto's range, or in terms of
let's go into that. I just want to get those.
Yeah.
Right. Yeah. So that's a great transition out of the thyroid kind of definitions I wanted to come to. I just wanted to make sure we mentioned those other pieces about the gut before we got here. So perfect, perfect prompt. So there's a couple, I think, important factors to identify, and maybe the first and most important and kind of most big picture is this person truly hypothyroid or not? And what I mean there is, are they high according to the conventional range for TSH, and are they low for T4? And if they are, then they're true hypothyroid, and most likely that person is going to need to be on thyroid hormone at least for a little while you try to potentially fix a problem in the gut that may underlie that. In my opinion, you certainly don't want to have someone walking around in a frank hypothyroid state. Now, so people who are truly hypothyroid are, in my opinion, going to need some medication, at least in the short term. People that are not hypothyroid, meaning they don't meet that criteria of conventionally high TSH, conventionally low T4, but are exhibiting hypothyroid-like symptoms or minor imbalances where maybe they're in the normal range, but they're at the high end of the normal range for TSH or the low end of the normal range for T4, and they're maybe flagged positive or negative, high or low according to a more functional range. In most cases for those people, where I think it's best to start is looking into other systems of the body as potentially being the contributing factor for that, oftentimes the gut and the inflammation and the thyroid autoimmunity that can be fueled by problems in the gut. So I first look to see if someone is truly hypothyroid or if they're more just functionally imbalanced. And if they're functionally imbalanced, I don't look at the thyroid as the root cause of the problem, but rather another system of the body. But there's also this subclinical hypothyroid, which can throw people. And subclinical hypothyroid is where TSH is high according to the reference range and T4 is normal. And there's debate regarding if subclinical hypothyroid is something that needs to be addressed or not. And I think it's important that we understand this as practitioners, because while it's great to treat people, I think it's also equally as damaging to over-treat people. And it's one of the things I think that our field really needs to update. I think we all want to help people. We're all trying to be progressive and open-minded, but the other edge of the double-edged sword of being progressive and open-minded is you risk creating a problem where there is none, or diagnosing a problem when there is none, or treating a problem when there is none. And that can come down to patients feeling like they have a problem when maybe they actually don't, and undergoing treatment when maybe there's actually not a problem. So subclinical hypothyroid falls into that kind of gray area of, what do we do? How can we be progressive but also maybe a little bit conservative? And so managing the conversation and the clinical decision-making around subclinical hypothyroid, I think, is very important. So there's disagreement, but there's also, in the research literature, but there's also a few trends. One of the things that can be very helpful is looking at the level of TSH elevation. Now, if someone is, instead of being, and I'm not sure if the units are the same in Australia as they are in the United States, but 4.5 is usually the cutoff for TSH. If someone's above 4.5, then they're going to be considered high for TSH. So if someone comes in at 5 or 5.5 or 6 or 7, for their TSH and their T4 is normal, then that person may not require any treatment, because and in fact, I believe it's the majority of people who are subclinical hypothyroid will spontaneously go back into the normal balance with time. So if the TSH is only marginally elevated, meaning it's underneath 10, there seems to be agreement in the literature that those patients don't require any thyroid hormone treatment because they're not truly hypothyroid. There's also an aspect of this that's important, and that's age. For people that are above 65 and people that are older, it's not abnormal to see the TSH slowly creep up over time. So if someone has a TSH above 10, but they're also over 65, then they may not require normal. Of course, that's given that they're subclinical hypothyroid, meaning along with that elevated TSH, their T4 is also normal. Whereas if someone was 18 and their TSH was 9, then that person may be a better candidate for thyroid hormone replacement therapy. And these recommendations are a derivative of looking at what happens when we treat people with thyroid hormone who have subclinical hypothyroid, and we track, do different morbidities, mortalities improve, or do they not change at all? And it seems that there's not a lot of benefit unless you treat within the criteria that I just laid out, with maybe 2 exceptions. The one most notable is pregnant women. It seems the literature seems pretty much in agreement that women who are trying to get pregnant and/or are pregnant and are subclinical hypothyroid should be treated. And then I would also add to that, someone could be a better candidate for treatment of subclinical hypothyroidism if they've done kind of everything else and they still have symptoms. So if they've improved their diet, improved their lifestyle, cleaned up their gut health, and all these other things are improved now, but they're still symptomatic, then a trial of thyroid hormone replacement therapy, may be a good idea for those people. So that's kind of speaking to the thyroid part. And then there's also the autoimmunity part, which I think there's a little more to say about, but I guess I'll pause there for a second if you want to go into any of those pieces.
I really appreciate you giving me the pauses to interject, because I totally agree with you in that. One of the things that happened to me is when I was practicing in Montana, I actually prescribed a whole lot more thyroid hormone than when I came here, and I didn't have prescriptive rights anymore in Australia. So I couldn't. And I think in retrospect, I may have become a little lazy, right, with my, and I think there is an element of overprescription of thyroid hormone, is my point to that. But I think that a lot of functional practitioners would argue the TSH of 10, and I think that there are different opinions. So I just wanted to mention that, but I appreciate you laying out that that's what it shows in the literature. It doesn't necessarily mean case by case. Case by case basis is always a bit different, but I do agree with you that looking at underlying causes as to why the thyroid is doing what it's doing, or is it the thyroid? If you clear that up, then you may not actually need to give thyroid hormone. So I appreciate that point.
Thank you. And also remember that that's the TSH above 10 in someone that also has a normal T4. That's really important.
Although a lot of people would, I have a lot of practitioners that say that oftentimes the T4, whether that's free or total, is almost useless unless they are really out of range, because it really doesn't indicate what's happening intracellularly. But that's a whole nother conversation. So I think for the sake of what are the actual lab values that we would associate with subclinical hypothyroid, that would be an elevated TSH and a normal T4. And you don't look at T3 or free T3 or anything like that?
Well, I used to. So and I still do occasionally, but admittedly, I have done less meticulous thyroid care as I've been looking at the labs, because there was a few years where I really ran the full profiles, and I was very meticulous with trying to get everything into these tight functional medicine ranges. And I found that what that actually ended up doing was distracting me from doing a good job with the gut care. And the better I've gotten with improving someone's gut health, the less relevant a lot of these nitpicky ranges with thyroid have been. And then I started looking at the medical literature and said to myself, wow, we've already done a lot of these studies where we've shown that people who are subclinical hypothyroid who go on medication don't really feel much better. And it's important to mention that just because you have patients say that they feel better doesn't mean it's actually because of the treatment. Because in randomized control trials where they are set up to guard against placebo, the placebo effect on average is 43%. So just because people tell you they're feeling better doesn't mean you're not over-treating them. And so I'm not trying to say anyone's right or wrong for doing what they're doing, but I try to be conservative and always trying to find the least amount of stuff that will garner the maximum amount of result. And I've been doing much less thyroid testing and focusing more so on, I guess, treating the person rather than treating the lab values. And I've seen probably better results in terms of the outcomes that people are having in the clinic.
I think that's really the take-home point. I think that's great. I would wholeheartedly agree with that's our job, is to find underlying causes and not try to fit people into reference ranges. Okay, so moving on, I know that you paused for me, so you might want to go back to the stream of thoughts that you were having, or I'll throw out another question about how do you sort of diagnose any thyroid condition? Do you just purely go by symptoms if you're not testing, or do you like you just said, you just basically, if somebody has thyroid symptoms, you just focus on treating their gut or their other metabolic issues, and then the thyroid sort of normalizes? Is that what you're saying?
Well, the preliminary thyroid evaluation is a bit more admittedly rudimentary. We'll look at TSH. Usually we'll look at total T4 and then free T3 and also their thyroid antibodies. And I'm looking to see, is this person truly hypothyroid, and meaning their levels, and if they are, we're going to get them on a medication. If they're already on medication and showing hypothyroid, then we're going to want to adjust their dose. But if they're generally normal in terms of their thyroid hormone levels, but they're still exhibiting thyroid-like symptoms, then we're going to look usually to the gut as being the cause of those thyroid-like symptoms. But there's also the other piece, which is the antibodies. And so that's the other thing. I think it's important to just speak to the antibodies, because there's kind of two tracks with the thyroid. It's the thyroid hormone function, meaning is someone euthyroid, they're producing adequate thyroid hormones, or are they hypothyroid? That's a one tract. And then the other tract is, are they autoimmune or are they non-autoimmune? So with the autoimmune, I'm sure, of course, we've all heard of the antibody testing, TPO and TG, thyroglobulin, being the two main. And then also, if you're doing ultrasound, having hypoechogenicity on the ultrasound findings being a ultrasound method of confirming this. I think we're all familiar with the antibodies, but there's some important nuance regarding the antibodies. And then this does tie into iodine, which you mentioned iodine a moment ago, so I want to make sure to touch on that briefly. So this is another area where I think it's really important that we be progressive, but also conservative in kind of the natural medicine, functional medicine approach. And I say that because I think we've drifted into a territory where we're a little bit overzealous in terms of looking at the levels for some of the thyroid antibodies and what we interpret from those levels. Now, what I had noticed a few years ago was when patients come in totally naive to any kind of treatment, meaning they're still eating gluten, they're still eating garbage, right? Their gut's all inflamed, and they're just generally not healthy. And we looked at their thyroid antibodies, we might see 1,100, 1,200, 1,400, 1,700. We're going to see a frank elevation of their TPO, which usually shouldn't be above about 30, 35. But then once we took steps to improve someone's health, and we clean up their gut, we clean up their diet, they're feeling a lot better, they've lost weight, they're sleeping better, their skin looks good, they don't have as many gut symptoms. Then I see the antibodies kind of start to hover around 100, 200, 300, 400. And these people were looking really healthy, and they may even have like halved their dose of thyroid medication from when they came in, and they're even feeling better on less thyroid medication. So globally, these patients look fantastic in terms of their presentation and their symptoms and even their lab work, yet they still have this low level positive for their TPO antibodies, again being maybe 100, somewhere between 100 and maybe 400. And it wasn't very surprising to me when I saw a study that showed that followed a group of patients that showed when thyroid antibodies were below 500, the risk of progression to overt hypothyroidism was very minimal. So that they tracked a bunch of patients that had thyroid autoimmunity, and they tracked them for years to try to see if there was a correlation between the level of antibody elevation and the risk for development of hypothyroidism. And they found that 500 seemed to be a cutoff where if someone was below 500, the risk was fairly minimal. And if someone was above 500, they had a higher risk. So that definitely fit with what I was seeing in the clinic, which was someone may be vastly improved, but still have a positive, a elevation of their TPO antibodies. But I was starting to look at that like a clinical win. So I guess what I'm saying in a somewhat circuitous fashion is when I look at antibodies now, if someone is between 100 and 300 to 400 in terms of their TPO antibodies, but they're presenting very healthy, then I look at that as a clinical win. And why I think that's so important is because a number of patients have come into me feeling stressed, scared, and nervous that their antibodies are still 225. And it's creating a lot of turmoil in their lives and a lot of stress, even though everything else looks good in terms of their health and their lab work. And I think it's important that we be aware of that, because that stress in and of itself may actually be more damaging than that TPO of 225. So I look at the antibodies a little bit more conservatively now, and I think it's important that maybe we all start to look at these antibodies in that way to prevent patients from unneeded, turmoil and anguish and fear.
Yes, I see something very similar to you. So that's great to hear that there is actually some validation in the literature about the levels of TPO. Although for me, it's almost like if I start out, if I see a patient that I'm testing TPO and they have 500, I'm thinking, okay, there definitely is an element of autoimmunity there that I want to explore further with looking at the gut and so forth. But I would never necessarily start with treating the thyroid for that. I always look at those other factors. But if I have somebody that was 1200 or above, then we can reduce it and they're feeling great, I completely agree with what you just said, that may be just where they are hovering. It would be interesting to hear what other people are finding actually about that. But great. What about when you look at SIBO specifically, and we know that there is this leaky gut, we know SIBO increases intestinal permeability, and of course we all know that intestinal permeability is really a huge driver of autoimmunity, and that has a link with Hashimoto's, one of others in terms of the connection to Hashimoto's. But do you see any other connections other than the leaky gut connection to SIBO?
I do, and let me just step back for one quick second, because when you were talking, there was something that just popped in my head I wanted to make a quick note of. I totally agree with you that we can still treat patients even if they're at a TPO of 500, right? What I'm saying is if we've done everything that we can reasonably do for thyroid autoimmunity and someone's feeling healthy and they're still at 400, don't keep telling them that something is wrong with them, right? And making them, walk around every day feeling like I'm broken, I'm inflamed, I have this flaming autoimmunity. We can let them know that, I consider this level, even though it's considered quote unquote positive, I consider this a clinical win, and I think you're going to do just fine. And from the research that we do have, that's been shown to put you at a very minimal risk for any sort of future problems with this. So I just want to quickly make that one note. And one other note, in case people have come across this study, there's one study that concluded that for patients that had TPO antibodies above 100, it was correlated with a decreased psychological well-being. And that's true, but if you read the study, they were defining TPO positive as over 100. So what they were essentially saying was people that were positive for thyroid autoimmunity had a poor psychological well-being than people who were not positive for thyroid autoimmunity. When you look at the details of the study, the people that were positive for thyroid autoimmunity had an average TPO of 1122. So further kind of reinforces that point of the high TPO antibodies are deleterious, but the more mild may not be. So I just want to throw those couple of things in there. And then to your question of, other things that I see, what were we asking? I'm sorry, the SIBO, other connection between SIBO and thyroid, or other connections between SIBO and just other problems in general?
No, I meant other thyroid issues. Like we know that the intestinal permeability, we can reason through, we understand that pretty well in terms of not just the Hashimoto's, but pretty much other autoimmune conditions. But I'm specifically interested in what do you see are other drivers or links, potential links between hypothyroidism, let's just say Hashimoto's, and SIBO. I mean, that was really interesting about the H. pylori and etc., that connection. So are there any others that are positively associated with SIBO?
There's been a couple studies that have shown that hypothyroidism is linked with poor bile function. And bile, of course, is antibacterial. And so if someone doesn't have adequate bile production, we can certainly assume that they're going to be at increased risk for small intestinal bacterial overgrowth, because bile is directly antibacterial amongst other things. So part of the thyroid SIBO connection may be the fact that people that have hypothyroidism have poor bile production, and that puts them at increased risk for small intestinal bacterial overgrowth. And what's funny is we can even kind of reverse that and note that SIBO is known to deconjugate bile and interfere with bile function in and of itself. And it might be this kind of self-feeding cycle where the more SIBO, the more it unconjugates bile, and then bile doesn't have quite its same antibacterial effect, further allowing SIBO to grow. So that would be the other, I guess one of the main others that I can't say I've seen. We don't do a ton of in-depth bile assays, but it's something that's been observed in some of the research literature.
So is that like cholestasis, or is it poor bile flow, or is it, because that's like what comes up in my mind is phase 3 detoxification, obviously removing bile and being a carrier of detoxification products. So right. That's where I go, is in terms of Hashimoto's. My thoughts are the drivers of that would be heavy metals, other pollutants, viral or other infections. We kind of think about what's really causing that, because the thyroid, my understanding is that it's like a primary source of concentration of mercury in particular. So it obviously then also interfering with glutathione peroxidase and all that. So that's really interesting. And I always love being the practitioners that we are. We think laterally and we think outside the box in terms of what are the connections to these different conditions. So, that's just my other thought about poor bile flow and SIBO and hypothyroidism, Hashimoto's in general. Okay, great, excellent. Okay, let's see. I have a list of other questions, and there's so many other questions, of course, that were just stimulated by all of that. But so, what are you, mainly doing in terms of treatment then when somebody has Hashimoto's? Just curious. I mean, you just talked about how you fix the gut and all of that, but what are your preferred treatments?
Well, if we're looking for Hashimoto's specifically, there have been a couple studies that have, and this is probably not news to anybody, but there have been a couple studies that have shown that supplementing with vitamin D lowers and improves thyroid autoimmunity. But it's important to make a clarification there, which is there's been a lot of association data showing that low vitamin D is correlated with thyroid autoimmunity. Association data is one thing, clinical data is another, and that's where we haven't had as much data. And there's only been 2, to my knowledge, studies that have really shown that supplementing with vitamin D then will decrease thyroid autoimmunity. And one was even more notable than the other, wherein they took a group of patients that had somewhat normal vitamin D, and they waited until after these Hashimoto's hypothyroid patients had been on thyroid hormone for 6 months until they started the vitamin D to isolate for the effect of vitamin D, because levothyroxine and other thyroid medications have been shown to have the ability to decrease thyroid autoimmunity, likely because when you give hormone, the gland doesn't have to produce the hormone and the gland can focus on repair, and there's less gland blood barrier permeability, so there's less antigens presented to the bloodstream, so there's less activation of the immune system. So we do know that thyroid hormone medication, for whatever reason, decreases thyroid antibodies. So if we had this group of patients with Hashimoto start on thyroid hormone and vitamin D at the same time, you wouldn't know if the effects of improved thyroid autoimmunity were from the vitamin D or from the levothyroxine itself. So they first had patients to be on thyroid hormone for 6 months, then they started on to the vitamin D. And many of these women in this study had vitamin D that was somewhat normal. It was above 20, so maybe not ideal, but they weren't startlingly low. And they did show, I believe it was a 40 or roughly a 40% decrease in thyroid autoimmunity. So maybe nothing new there, but there's been another study or two looking at the supplementation of selenium, CoQ10, and magnesium, and they've shown a beneficial effect on thyroid autoimmunity, and there's some data showing even an improvement in that echogenicity, or the structural changes on ultrasound that are found in the thyroid gland after supplementation. We've probably all heard of selenium, but some other studies have combined selenium with CoQ10 and with magnesium and showed effect. And it's important to mention on selenium, I think we're most probably in agreement that selenium is not a bad idea in terms of a consideration for thyroid autoimmunity. But to be truly objective, not all the data agree that selenium is helpful. And one study in particular, I thought, did a terrific job of breaking out the time response to selenium. So this study looked at response of antibodies to selenium supplementation, and they looked at a 3-month, 6-month, 9-month, and 12-month interval. And they showed the most benefit was at 3 months, and then once you went over 6 months, the benefit of selenium supplementation on thyroid autoimmunity diminished and was pretty much non-existent. Why that's important is because interesting. Why that's important is because some of the data, and I'm talking high-level systematic reviews with meta-analyses via the Cochrane database, which is like our gold standard, they have not conclusively shown that selenium helps with thyroid autoimmunity. So, we as alternative practitioners can do one of two things. We can ignore that because we don't like what it says, or we can try to account for that and be reasonable. And it's not good for us to ignore that, because we get mad when conventional medicine ignores obvious information that supports natural medicine. So we shouldn't do the same thing back to them. When there's evidence potentially refuting something that we believe in natural medicine, we want to be open to that and be thoughtful on that. So what may be happening there is we're seeing the non-agreement in the high-level scientific data because we haven't delineated the length of time of treatment. So it may be that most of the benefit for selenium specifically is realized between 3 and 6 months, and after 6 months there's not much additional benefit. And also, why that's important, coming back to a conservative model of functional medicine, we don't have to keep people on selenium forever now. We can run a shorter course of selenium, yield the therapeutic gain, and then from there just focus on food. So those are some of my go-tos for thyroid autoimmunity specifically. I have some thoughts on medications, but I'll pause there for anything you want to add.
I think that's a really good point about looking at repletion of nutrients. I mean, it doesn't mean that you have to do this nutrient forevermore, but looking at total nutrient repletion and then maybe cessation of supplementation. And that's a very holistic approach anyways. It's not like otherwise it's just like you're using nutrients like medicines forever. So that's a really good point, is that maybe it was just about bumping up levels of selenium for glutathione peroxidase, whatever, and once it's replete, you can stop doing that. So that's a good point. Okay, so let's quickly talk about medications that you want to get into, and then I think we need to sort of concluding it. I wanted to also quickly talk about what you have to offer at the end of this, and then just also mentioning, you and I had a conversation, and one of the things I really appreciated about the conversation in Chicago was you were talking about that I don't know if you said the word mission, but I sort of interpreted it that you really feel strongly about, as a functional practitioner, to not have people spend thousands of dollars unnecessarily on testing. And
Right.
that, you know, and I really appreciated that. I think a lot of people, some people do that out of, like, I don't know if it's insecurity or what, that they feel like they have to do every test under the sun. So just to kind of dovetail on that, I just thought, what are your favorite tests to order? And just kind of talking a little bit more about that. But
Yeah, no, definitely. I'm happy to.
Yeah, let's talk about the medications that you were talking about, and then we can move into that. How about that?
Okay, sure. That sounds great. And I should just mention, I think this is probably implicit already in our conversation, but obviously, definitely treating someone's gut, if I suspect autoimmunity, that's, without question, I'm certainly going to try to optimize anyone's gut health, whether that be H. pylori or SIBO or both, or Candida, or just general inflammation, or what have you. That's going to be a foundational approach for any type of autoimmunity. Will be addressing their gut. So probably goes without saying. I just want to mention that really quick. In terms of medications, there's a couple of things here that are probably pretty obvious, that the majority of patients seem to prefer a T4, T3 combination formula like NatureThyroid or Armor or Westthyroid or what have you, and that's been borne out by some of the research studies. There was one study somewhat recently in particular that it was a double-blind crossover study, meaning both treatment groups in the study experienced both treatments, so we could get a really good look into the response to a given treatment. And roughly speaking, 48% preferred a T4, T3 combo, 18% preferred T4 alone. And the main symptoms that denoted the group that preferred the T4, T3 combination treatment were weight loss, and there was about 3 to 4 pounds additional weight loss in that group. So not a huge change, which is important to mention, but 3 to 4 pounds is 3 to 4 pounds. And also just general subjective well-being indices. So I think something like a SF12, like a short form 12, which is just kind of a general, hey, how you doing survey. It gives you a general quality of life assessment. So a T4, T3 combination is definitely something worth considering. But there's something else that I think people may not have heard about that's worth keeping in mind. And this is looking at a liquid thyroid hormone. For some people that maybe have tried so let me paint a different picture. So if it's a patient that has pretty progressed gastrointestinal whatever, maybe it's a SIBO that's very recalcitrant, or inflammatory bowel disease that's mild to severe. If there's some kind of ongoing gut problem that you're managing, but it's still always going to be there. And we all see those patients, right? These are the patients that fall on the more severe end of whatever spectrum it is you're dealing with. They're probably going to feel a lot better after they've been working with you for a little while, but they still may never be perfect. Again, severe inflammatory bowel disease is a good example of this. These people will feel a lot better. They may, prevent the need for surgery and be functioning a lot better, but they may always have a little bit of low-level disease activity that is there. For these people that have kind of these ongoing gut problems, some evidence has shown that they'll do better with a liquid form of thyroid hormone. Now, this in the United States is known as tyrosine, which is liquid put in a gel cap. So it's not truly a liquid like you pour the thyroid hormone onto a spoon and take a tablespoon. It's a liquid, but it's in a gel cap. But they have shown that for those, for example, with H. pylori, they actually have better absorption and stabilization of their thyroid hormone levels when using this liquid form of thyroid hormone. They've also shown that you don't have to fast. So you can take this liquid form with food, and food won't compete with the absorption. So that's something that may be a nice pearl if you have a patient with compromised gut integrity, that even at best, it's not going to be great, and they haven't felt great on other thyroid formulas that they've tried. You've gone through the general trial of a T4, T3, and you've tried a few dose adjustments. You haven't gotten anywhere there. Then you switched over to a T4 only. You haven't gotten anywhere there. Then you may want to try a liquid only formula, because they seem to be much more easily absorbed in those that have these underlying malabsorption type issues. So that was just something with the medications that I wanted to throw in. And there's been enough studies that have shown that I think it's worth, it's not like we just have one speculative study. There have been a handful of studies that have all shown this kind of similar sort of result. So something there that I think is
that's
worth
really
mentioning.
helpful. Yeah, that's really helpful. Thanks for that.
And then regarding testing, pretty basic. I run TPO antibodies, thyroglobulin antibodies, and then I look at TSH, usually free T4, sometimes free, sometimes total T4, and then free T3. And that's pretty much the extent of the thyroid evaluation I do. Of course, gut evaluation is a different thing, but that's what I do for thyroid. And it's tempting, right? When I first learned about the serum selenium level that was needed to be achieved to reach optimum glutathione peroxidase function, I ran that marker for a little while. But after a while, I said to myself, this isn't really changing what I'm doing in practice. I'm not that prescriptive with my dose. I don't need to be that prescriptive with my dose. In fact, I would argue if you're too prescriptive, you don't do a good job of just looking at the general trends in the patient in front of you, and you get too in your head about all these numbers, and you more so start treating the numbers than treating the patient. So that's just one example of something that you could test. But I think if we're asking ourselves constantly that question, is this essential? We can kind of weed out the non-essentials and come back to, as you said earlier, a testing model that's not going to be prohibitively expensive.
Great. Are there any gut tests besides breath tests that you frequently do?
Breath test for SIBO, of course, and then for H. pylori, since we mentioned that one, I like to get a blood sample for 3 fractions of the antibodies, G, A, and M, and also I'll do an H. pylori breath test and an H. pylori stool test for stool antigen. And then I oftentimes will do kind of a complete stool test, and oftentimes I'll pair that with blood or sometimes serum antibody testing for things like amoebas, and also candida antibodies that you may not fully catch in the stool as part of kind of our non-SIBO part of the gut workup.
Great. Well, Dr. Ruscio, this has been really wonderful. Thank you so much for your time. I think you also wanted to mention that you have something for practitioners coming out soon? Some sort of
yes.
Newsletter or masterclass.
It's been out for thank you. It's been out for a little while now. We launched this in January of 2017, and it's essentially a clinical newsletter. There's one case study, and it's a very detailed, very real case study. It's easy sometimes to just take your best success stories and make a case study out of that. But these case studies are admittedly kind of a pain in the butt for me to put together because there's so much detail that goes into these. But the feedback that we've gotten on them has been great because they're real cases where we have to think and change and observe and modify and kind of work a little bit to get the result. So there's one case study. And this is every month. This is a monthly newsletter. So there's one case study. There's 3 to 5 research study summaries, like the one I was mentioning earlier. And these are all highly clinically relevant studies. There's no academic fluff here. These are very just important clinical studies. And I give you a breakdown on here's what was found, here's what this means, here's what you should do, and here's my interpretation on this to try to make it easy to take away, what might otherwise take you an hour or two from just reading through the study word for word. And then the third and fourth sections are a practitioner question of the month. We listen to some of the comments and feedback, and we take either the most common or the most important question that we've received in previous months and answer that in a future month's edition. And there's also the final piece is I put out a practice tip every month. I think last month we talked about a very easy HIPAA compliant online form builder. We've previously talked about the hiring process we use in our office to make sure that, which I'm sure people listening understand how debilitatingly of a time suck it can be to have to restaff someone. But we've come up with a very smooth system for hiring people, and there's essentially 3 to 4 phases of screening, and a lot of it is automated, and it just makes the process of hiring someone new so easy. And so that was something I talked about in a previous month also.
Wow, that's very different, isn't it? So, but your newsletter is more all sort of areas of, or this case review is all areas of functional medicine, or specific to thyroid, or specific to gut, or anything?
The topics, the topics, there's definitely a focus on gut and thyroid, but we do go into other issues that are important also. Like we reviewed a study recently about sun exposure and how the evidence showing that sun exposure increases cancer is probably a little bit actually, false, and how there was many health conditions that were shown to be protected by sun exposure, and cancer didn't seem to change. So yeah, I mean, there's things like that are basic, or maybe we talk about, the paleo diet and hunter-gatherer and ancestral health principles, or sun exposure, or stress, or sleep, or whatever. But the focus is definitely the gut and the thyroid.
Great. Well, thank you very much for your time today on the SIBO Doctor podcast.
Thank you, and let me just tell people, in case they're wondering where they can go to track this
yes,
down,
that'll all be.
website.
Yeah, sorry about
Thank
that.
you
Yeah,
for
go ahead,
listening
because
to
it'll
the
be all in the
SIBO
show
Doctor
notes.
podcast. We hope
okay.
you
So
found
it's
the
just
information in this
drruscio.com, which is
episode useful in the treatment of your SIBO patients.
drruscio.com, and then if you wanted to
Head
check
over
out
to our
that
sponsor,
newsletter, it's
SIBOtest.com, an
drruscio.com/review.
online testing service
Great.
for your
Thank you very
patients
much, and
and
for those
home
listeners
of the
who are
practitioner
interested,
education
but
portal.
please just go to the SIBO
Tune in
Doctor
again
Podcast
for another
and all the
episode
show
of the
notes,
SIBO
and
Doctor
links, and Dr.
Podcast.
Ruscio's
Thanks
contact
again for
details will all be
listening.
listed there. So thanks again, Michael.
Thank you. It was a lot of fun. Thanks for having me.